So good morning to you all to this small scientific cafe, a 20-minute presentation. We're going to tackle the difficult subject of how to go beyond somatic dysfunctions. And this is a presentation of how to truly integrate the biopsychosocial model in the way we see our profession. So the first element, which I think most clinicians are aware of, is that context matters. So here we have a box placed on the floor with two rabbits looking at us, and the question is, how is the open box placed? And we might have, each of us have a different interpretation of how we see the box. But in reality, if we put the rabbits inside the box, we have further information, and then we can see that it's actually resting on the floor, or it's a tilted camera and it's to the side, or maybe the box is simply nailed to the ceiling. And the information brought by the rabbit made this information possible. So just looking at the box doesn't give us enough information to know where it is and what's going on. And this is quite important in clinical settings because it shows that we need a complete vision of the situation to be able to know what's going on and to give meaning to our treatment. So I'd say up to the end of the previous century, osteopathic care and the scientific approach to osteopathic care was targeting physical care. This was also historically due to the fact that in the United States, coding had to be done for reimbursement, and somatic dysfunction was named as an entity to make it possible to have an osteopathic diagnosis and be refunded. However, when we see the broader perspective of what osteopathic care is and what we do, we can see that there's much more to it. And it's not only physical care, but we also do behavioral care, cognitive care, and emotional care. This is not specific to osteopathic care. It's more general to any approach where we are person-centered. So here I have a few examples, like in physical care, it might be physical reactions to treatment. So it can be due to medication, surgery, but also maybe manipulation or exercise. The behavioral response is the way people would adhere to exercise or lifestyle changes, what we do changes in their life. And this is very important in osteopathy because if you change perception, people will move differently. And so this change will reinforce their good health and their better health in the future. The cognitive response is more about beliefs and perception. What we think we have and what meaning do we give to what we have? And the emotional response is more fear, anxiety, depression, and denial, which is very important in osteopathic care because many people have movement avoidance and such schemes. So overall, changes in perceptions can lead to better health outcomes, but these don't only address the physical aspect of care, but also other components. So how does this fit into the osteopathic conundrum? And what is the osteopathic conundrum? So here we are. I think this is an epistemological choice. So we can either remain in a framework that's maybe more simple and comfortable, but we're out of the reality, or we can choose to face the reality. And I think evidence-informed practice is about choosing the red pill. So I suggest, and given you're here today, I think it's maybe because you're willing to take the risk of taking the red pill. So let's dive in out of the matrix. So the first point which has been highlighted is the lack of consensus about somatic dysfunction. So we have now about 20 years of research trying to provide better information of what is somatic dysfunction. And we haven't found a common agreement. It doesn't mean that we can't see structural and tissue changes following osteopathic manual treatment, but there's no clear link between what we feel and what we see. In other words, we found out that osteopathics have different interpretation from their tests, and that there's not a common agreement of what is defined as a somatic dysfunction. This is problematic also for diagnosis, because to have a diagnosis, we have to have a clear mechanism and we have to know what is the dysfunction related to. The second point where we've had difficulties is reliability. If we take tests out of their context, they usually don't have any meaning whatsoever, which means that the somatic dysfunction isn't an entity that has a meaning out of the context. It also means that the somatic dysfunction might only appear in certain types of interactions, but not all the time. The third element is the specificity of the physiological response to OMT. We know that treatment provide many different responses and that they cover a broad spectrum of different physiological entities. It can be on the vascular system, it can be on the neural regulation system, it can be on the emotional response, it can be on the movement execution, and so on. And the last point, which is part of the osteopathic conundrum, is the paradox of sham manipulation. If we do a waiting list, we can see improvement and patients do get better. But if we use sham manipulation and there's a true blinding and people think they receive a treatment, then there's very little difference between groups. And we believe this is due to the fact that treatment is not only related to the corrective maneuvers, but more the whole management of patients. And this is what we're going to see in the 15 next minutes. So how do we move beyond somatic dysfunction? How do we try and understand osteopathic care as a shared experience between a patient and the practitioner? Well, first of all, let's just take a simple example and moving back to pain. Because if we look at pain in the way we used to perceive it and the knowledge we gained during, I'd say, the last 40 years, we have similar approaches and this makes it possible to understand where we're going to and how can we overcome just the biological or biomechanical view of osteopathic care. So on the biological dimension, pain is a stimulus and it activates a receptor, and then there's a signal that goes up to the brain, and then it's processed, and there's a response and a perception of pain. So the stimulus is a nociceptive stimulus, and we can reduce it using drugs or any element. And we could reduce the explanation to pain to simply that explanation. But then we can start seeing that people with similar stimulus have totally different experiences. So we need to move beyond the pure biological dimension and start seeing what's the psychosocial dimension of pain. So there can be the sensation, which will arise from the stimulus, which is really dependent of the level of awareness. What am I focused on? And can I feel the pain at this moment? I think people have experienced playing a sport and maybe hurting themselves, and the pain is not so important until they rest and they can focus and their awareness is brought onto what's happening. Or even being very concentrated and doing something and cutting oneself without feeling anything, and the pain comes once we notice that the wound is there. And the third level is really the perception, the interpretation, what's going on, what's happening. In other words, is this signal I'm feeling, is it a danger or not? And how the brain is linked to previous experiences or expectations that make us feel pain or not. And the whole experience of pain is all these components taken together. In other words, we can see that the psychosocial dimension is very important. And now let's see what osteopaths do and whether this psychosocial component in their own approach of osteopathic care is also important. And we can see that for about 30% of consultations, osteopathics report that part of the intervention is related to lifestyle advice or self-management, relaxation, or dietary advices. This is data from the OSTO survey, which is a large survey done in Switzerland. So we can see that osteopaths recognize that their skills is not limited to just manual therapy, but that they have a broader scope of care related to patients. And this leads to the contextual dynamics of how do we actually work with a patient, and how do we actually broaden the vision of what we do to simply doing corrective maneuvers. So I'm just going to try and explain. This is from a model from published by Lehmann. It's been used for a while, but it really shows that things interact one with another. So the biological dynamic is the way that osteopath would more relate that to the structure. But these relate to the psychological dynamics, which also increase with time, as we've just seen with the pain example. And then there's also an interpersonal dynamic, so the way people interact with other people, and it's more the societal dimension. And all these interact and define our health. And the interaction of these three dynamics define what we call the contextual dynamics, which mean an osteopath, when he's seen a patient, he doesn't only have interest on the symptoms or the pain or the disease itself, because the osteopath does not treat a condition, it treats people. And to understand the person, usually the osteopath will also have interest in logical dynamics within the problem that the patient is facing, and also the interpersonal dynamics. So we have a broader approach of patients that has us understand, but also in the treatment, these elements play an important role in the way we approach and touch the patient. So let's get to touch. I'll just put aside all the known components of care, which is about taking the time to understand the patient, maybe communication skills, empowerment, and so on, which is also part of the consultation, just to focus a bit more on what meaning can we give to touch and perception. So the first thing to know is that the way we interact with patients is really, our understanding of how it works has really improved these last 5 years, 5 to 10 years. And I've just retained here two important models that we could use to understand what's going on. And these are the interoceptive inference theory from Van den Berg and the embodied and active theory from Auberg. And they're quite compatible one with another. The first one is more an explanation of how do we perceive things, and the second is more how do we perceive oneself, so how do we anticipate. So the interoception inference theory is more on the awareness side, and the embodied and active theory can more go on the social and our history. So one defines the symptom perception, and the other one is more the self-perception and the self-confidence. What we do know is that both these different underlying theories, so the way we self-perceive ourselves, the way we're self-confident, and the way we perceive symptoms, well, that can enhance changes in expectations and perception. So when an osteopath works with a patient, probably what we're doing is modifying the way people, so the interoception, the way people feel things, but also the way they perceive themselves. So let's get a bit more into this and understand this more in detail. So what we have usually, this is advances in neuroscience, we have what we call prior expectations. Our brain needs to see our world in a unique way. We need to be a unique person, and things have to happen at the same time. But signals come to our brain at different rates. Audition comes faster than vision, and touch comes at different latencies, depending where it's coming from or what receptor it's coming from. But at the end, when we're touched and we see someone is touching us, or if we even slapped on the hand, we hear, we see at the same moment. And this is due to the fact that we actually anticipate what's going to happen, and we create the sensation before the afference comes in. In other words, everything that comes from our captors are only there to confirm what we think is going to happen. So we have an awareness of our environment, and we're all the time predicting our perceptions. And then the symptom perception will arrive, and then we'll see if the experience corresponds to what we predicted. And if that's the case, it reinforces the loop. And next time we'll have a better expectation and a better vision of what we do. And that's why we can play ping pong, for example. If our prediction is wrong, then we notice it, and the prediction is reset and can be adapted for it to be better in the future. So that means the symptom perception is really related to prior experiences and the way we're going to predict it. So if someone has low predictive precision, it will reduce symptom perception. It can also be high attention to negative sensation. That will also reduce the symptom perception. High sensitivity to contextual cues. Well, that can also reduce the symptom perception during treatment. And if we have threats and negative effects, that will increase the symptom perception. And if we look at the feedback loop and what this creates, well, with pain, it can create sensitization and chronic pain. It also will create movement-induced fear and avoidance due to previous experiences, and it can also create loss of confidence. So we see that this perception and the way we predict, depending of what's going on and the events we have in our life, can lead to feedback loops, which creates well-known symptoms that we see every day in our office. So how can we shift from the osteopathic care model to which was closely related to the somatic dysfunction, and include these concepts into our care? Well, I think these three elements are the elements we work a lot on when we're working as an osteopath. So we're going to modify the cognitive and affective state of our patient. We're going to manage and help self-efficiency and coping with pain or other symptoms, and we're going to change health behaviors. So that means if we see osteopathic under this light, the touch is a whole process where we're modifying the way people perceive their own body. And we're going to a mutual understanding of what's going on. Hilary Abbott was talking about walking through an experience with the patient, and that an osteopathic treatment is actually sharing an experience for the patient to be able to change and modify their perception. And in that sense, we can say that we are professional of what we can call active touch, which is a mean of communication that's embedded in our system. And the active touch depends also on the quality of the way that an osteopath will approach a patient and the way that he will adapt his movements, his touch to what the patient perceives. It does create a shift in our conceptions because we're not looking for somatic dysfunctions, but we're looking for responses to what we do. So it's in an interaction, the patient responds to what we touch, and we're very aware, and this gives us important information that will guide us into the change that we want to bring to our patients. And this leads that with active touch, we can help patients overcome pain and fear, we can surpass symptoms avoidance, and we can develop self-confidence, which were the 3 points we saw just before. And that means we'll improve interoception interference and allostasis. People will have a better adapted system for their environment, and they'll have a better prediction on how to perceive the world that's around them, mainly through touch and their body sense. What are the practical implications? So this is very theory-based, but what does it mean in our practice? Well, one main element is to see the key role of touch as a shared experience towards change. So we don't have a specific time set where we're correcting something that's negative or there's a problem or so on. Osteopaths are more solution finders. They try and find ways to enhance potentials that patients have, and trying to see how to avoid elements that they don't want to feel or live. So living the shared experience is a whole process, and the correcting maneuver is probably just a moment where we can create an interoceptive situation or change, which will have the patient be open to new perceptions, which are then reinforced with retesting and movement and so on, which means that the care is a continuity starting from the moment we touch the patient until the moment the patient can move around and perceive themselves the change in their own body. And today we think that there's no clear moment of a corrective maneuver. The process is all along the interactions. So let's provide a definition of then how do you see touch and feel it. Maybe one change will be this notion of active touch. So active touch is a communication skill to let patient's body tell their story and enhance changes in perception. And this is a big shift in the vision of osteopathic care. But this vision overcomes all the limitations we've had during the last year. And I think it's starting to be a broad consensus among osteopathic academics around this notion and similar definitions. This also opens the notion of clinical conversation and the application of touch to clinical conversation. So maybe some of you are aware already of the 4-habit model, which is a global education approach to help practitioners interact with patients. And it has different steps, like invest in the beginning and elicit patient perspective, demonstrate empathy, and invest in the end. But you have these emotional expansion, cognitive expansion, and coping expansions, which have been done for general practitioners, so not at all in osteopathic care. But we see that there's a perfect alignment between what we do through touch and what has been developed in these models. So this means that through touch, there's also phases during the consultation where we're going to create relationships with the patient, elicit patient's concern, and this we can do through touch. But also, we're going to try and see what's most important for the patient and what the patient is trying to avoid most. We're going to open patients' emotions through touch and experience. So we're using the associative meaning of what the patient might feel and why there's fear avoidance and such elements. And invest in the end. Well, there they wrote deliver diagnostic information. I think osteopaths actually deliver by enhancing change, meaning the patient feels different. They have an experience and they can feel that things are not set in stone and that there's hope for them to be able to be different. And that's also by promoting empowerment and focusing on coping. So what's your take-home message from all this? Well, I think this slide summarizes the whole speech, and it shows that osteopathic care is about improving function. And this leads through 4 different dimensions of care: physical care, behavioral care, cognitive care, and emotional care. And what we try and do as osteopaths is to alter tissues, alter actions, alter beliefs, and alter feelings. And that this has to be seen all together. And an osteopathic practitioner who will honestly and truly understand their patients and lead them to change will gain into recognizing his own skills in these different changes. Most often when we speak, we focus a lot on what was previously seen, the old osteopathy, which is about physical care, and we fail to recognize our ability to alter actions, beliefs, and feeling. But actually, we're very good in doing this. And so what can we do in our clinical practice? Well, I think it's with patients. It's more embracing the notion of active touch. Also, when we discuss with patients and we follow them up through the consultation, it's to focus on positive sensations and perceptions. Also have patients own the decisions of priorities and what are we going to address first in their symptoms or the change we want to bring. We want also to facilitate the change, which means the conditions we're going to use. We want to increase subjectivity and contextual effects, which will improve our ability to change the patient. And lastly, we want to integrate and reinforce what we do. So go back to testing and having the patient feel the difference, but also integrate these changes in usual movements so that the patients can then re-educate themselves on their own in their self-autonomy. I think this summarizes the main changes and the shift we're having in osteopathy that we've seen across academic fields. It doesn't change a lot in the way we practice. It mainly changes the way we see the way we practice. And I'm really looking forward to your questions and your comments about this approach and vision, and the floor for questions.